Okay, so in this lecture we talked about pathophysiology of the GI system and the reproductive systems, and we started with chronic gastritis, which is mostly going to either be caused by an infection with H. pylori or by autoimmunity. So for infectious cases, H. pylori is going to colonize the stomach, and then it will gradually, through its metabolism, break down the mucosa. And what happens is that subjects the submucosa to the acid of the stomach. And that's going to set off the inflammatory response. So immune cells like neutrophils will come into the site. It will start to phagocytose the bacteria. Macrophages, lymphocytes will come in, and that will create a chronic inflammation in the stomach. Now, in autoimmune types of chronic gastritis, there are autoantibodies that are produced against parietal cells. Remember, parietal cells are the ones that produce hydrochloric acid and intrinsic factor. So clinical manifestations, both of them can present pretty similarly. There might be some epigastric pain, heartburn, just a feeling of indigestion, sometimes loss of appetite, nausea. The autoimmune cases, if they're asymptomatic, may actually present with pernicious anemia, and that's due to the lack of intrinsic factor, which is needed to absorb vitamin B12. So as far as diagnosis, endoscopy and biopsy is going to be pretty standard. And as far as treatment, if it's infection, antibiotics will clear it up, anti-inflammatories, and B12 injections for the autoimmune types of chronic gastritis. And here you can see a slide of chronic inflammation in the stomach. So pancreatitis, inflammation of the pancreas, can be either acute or chronic. So acute types of pancreatitis often occur after a long period of chronic pancreatitis, but not always. But in acute types, the exocrine portions of the pancreas are damaged. These are the portions that produce the digestive enzymes. And this is mostly going to be due to alcohol abuse or gallstones. And what happens is these exocrine portions which produce enzymes, these enzymes will accumulate inside the cells. And when they accumulate, they start to activate. And they should not activate in the pancreas. And the pancreas can actually autodigest itself. Chronic pancreatitis is most often due to chronic alcohol abuse. And with chronic types, typically both the exocrine and the endocrine portions are affected. So the endocrine portions produce insulin and glucagon. So clinical manifestations, epigastric pain, umbilical pain. I'm kind of generalizing both of them. The pain can be severe, it can come and go, it can intensify. Diarrhea, vomiting, loss of appetite, increase in amylase and lipase are pretty specific. So it's a pretty nasty thing, not comfortable. As far as diagnosis, symptoms, history, amylase and lipase levels, AST and ALT, checking liver function, and imaging. Treatment, it depends on the type, so there may be just simple lifestyle modifications or the use of certain anti-inflammatory drugs, sometimes surgery, fluid correction if it's very severe, so it just really depends. And here you can see how gallstones, when they come down the common bile duct, they can actually block the main pancreatic duct. So these enzymes start to back up into the cells, and the pancreas starts to digest itself. So inflammatory bowel disease, this is an umbrella term for two main diseases, which are Crohn's disease and ulcerative colitis. And we're going to talk about each of these individually. So Crohn's disease, it can affect any part of the GI tract, so anywhere from the mouth to the anus. The cause is unknown, it's multifactorial. The inflammation that results in the bowel is transmural, meaning it goes through all four layers. So the pathophysiology, these progressive cycles of inflammation, which can come and go, will cause reactive lymphadenopathy, so the lymph nodes will become kind of filled with fluid as this inflammation basically causes edema. And this edema reduces the amount of oxygen, which can cause ulceration. You can have complications like abscesses and fistula. And as this occurs over a person's life, you actually get scar tissue that forms, and that can cause stenosis and can lead to an obstruction. So clinical manifestations, they're going to be similar between Crohn's and ulcerative colitis. So abdominal pain, diarrhea, and or constipation, with or without blood, fever, weight loss, loss of appetite, vomiting, nausea. As far as diagnosis is going to be based on history, physical exam, definitely an endoscopy, colonoscopy with a biopsy, CT scans, MRIs, fecal calprotectin tests, which measure a marker in the feces, and treatment, kind of immune suppressing drugs. So corticosteroids, the biologics, which I talk about a lot, pain medications for pain control, aminosalicylates. These are things like 5-ASA, sulfasalazine, avoiding any sort of trigger and just trying to optimize as much nutrition from your diet. So here you can see one of the characteristics of Crohn's disease are skip lesions, meaning you can have healthy bowel, sick bowel, healthy bowel, so on and so forth. It's going to be different in ulcerative colitis where the lesions are continuous throughout the large intestine. So ulcerative colitis, again, somewhat similar to Crohn's disease, but there are some big differences. First off, only the first two layers are typically affected, so only the mucosal and submucosal layers, whereas in Crohn's disease, inflammation was transmural. So this usually starts in the distal portions of the large bowel, so, sigmoid colon, rectum, and these lesions kind of spread upwards until the entire colon is affected. So clinical manifestations are going to be very similar. Diarrhea, often with blood, constipation for some, weight loss, nausea, vomiting, abdominal pain, all of that sort of stuff. Diagnosis and treatment is pretty much going to be the same as it was for Crohn's. The only difference is you can kind of technically cure ulcerative colitis by removing the entire large intestine, whereas in Crohn's, you can remove the sick piece of bowel, but it doesn't mean it's not going to pop up somewhere else. So here you can see these more superficial lesions, and they are continuous. So irritable bowel syndrome, I'm actually not going to talk about or ask about this in the final exam, but I just want to throw it in there because a lot of people confuse IBS and IBD. So I really just put this in here for your information, but I'm not going to ask about it on the exam. So cirrhosis, we've talked about cirrhosis before. This is a chronic liver disease where damaged liver cells, hepatocytes, are replaced with scar tissue. And this is going to be caused most likely either by chronic alcoholism or viral infections such as hepatitis C and hepatitis B. It can also be caused by right-sided heart failure. It can be caused by a chronic obstruction of the bile duct, but most commonly viral infection and chronic alcoholism. So basically this chronic injury causes these hepatocytes to die, and that tissue is replaced with scar tissue. And the scar tissue is going to obstruct the blood flow and just gradually reduce the overall function of the liver. So early manifestations of cirrhosis, jaundice, easy bruising because of the lack of clotting factors, abdominal pain, usually not too severe, but it can be, loss of appetite. And then late manifestations, this is when you see ascites. Okay, and ascites is that edema in the peritoneal cavity due to the increased capillary hydrostatic pressure and decreased capillary oncotic pressure due to the lack of albumin production. So diagnosis, liver biopsy will show this. Blood test, testing for liver function, imaging to see gross changes to the liver. And as far as treatment, paracentesis, diuretics to remove the excess fluid. Control of bleeding from ulcers and varices due to this increased pressure in the venous system, and that can be really dangerous if these varices rupture. Diverting blood away from the hepatic portal vein to, again, relieve pressure. Nutritional supplementation is always good. And here you can see ascites, of course, cirrhosis. This is what you would see on histology from the biopsy. Then we talked about diverticular disease. So there are two main ones, diverticulosis and diverticulitis. Diverticulosis just refers to the presence of these diverticula, or pockets, in the bowel wall. And these are typically going to be in the colon, most often in the sigmoid colon, sometimes in the ascending colon, but they can really be anywhere. They form when, diverticulosis is just the pockets. Diverticulitis, this is when these pockets become inflamed, typically by an infection. So these form when there's high pressure in the lumen of the GI tract, and this pressure puts stress on these weak points in the wall, and these are areas where blood vessels are coming into and out of the bowel. Now, and that's how the pockets form. In diverticulitis, basically something gets stuck in there, and that allows the bacteria to kind of replicate and form an infection, and that can be dangerous if one of those pouches ruptures, because that can cause peritonitis, which is invariably fatal without treatment. So diverticulosis, a lot of people don't know they have it. You just might have some mild discomfort. Acute diverticulitis, you'll have fever, you'll have rigidity, significant pain, and that's, you can classify that as a medical emergency, because peritonitis will kill you if it's not treated. So diagnosis, endoscopy, CT scan, history exam, all that stuff. As far as treatment for diverticulosis, just a bland diet, high fiber, seems to be beneficial. Stool softeners. And diverticulitis, sometimes surgery if it's really severe, definitely antibiotics, pain meds if the pain's severe. And here you can see these pockets. Okay, then we talked about reproductive patho, starting with BPH or benign prostatic hyperplasia. This is just an increase in the number of cells in the prostate, and therefore an increase in size of the organ. So this is most common in men over 50. The process seems to start sooner, and the cause is probably just a combination of things, multifactorial. So clinical manifestations, nocturia, urge incontinence, the feeling that your bladder's full even though it's empty, a weak flow, weak stream, the need or the feeling that you need to urinate frequently. Diagnosis, history and physical exam. Most men over age 50 are going to have some signs of BPH. PSA levels, prostate-specific antigen can be helpful. DRE, which is a digital rectal exam to feel a gross increase in size of the prostate gland. And as far as treatment, there are surgeries to remove portions of the prostate. There are some supplements, like, for example, saw palmetto seems to be beneficial to some people. Smooth muscle relaxers, because there's smooth muscle in the prostate, because the prostate has to contract. And anti-testosterone drugs. So here you can see a normal prostate, which sits at the neck of the bladder, and here is one that's enlarged. Then we talked about prostatitis, which is inflammation of the prostate gland. There are several different types of prostatitis, and most of them are chronic, and the cause of some of those cases are unknown. The acute types of prostatitis are typically infections, and those need to be treated, of course, and this is more common in men under the age of 50. So clinical manifestations, somewhat similar to BPH. So frequent urination, weak stream, sometimes pain, dysuria during urinating, lower abdominal pain, and maybe fever if it's an infection. Diagnosis, history and exam. Urinalysis, blood work, DRE may or may not kind of indicate the inflammation, depending on the how bad it is. As far as treatment, antibiotics if it's an infectious case. For some of the chronic cases, they use long-term antibiotics. There's a little bit of a debate about whether or not that's beneficial. Anti-inflammatories, other symptomatic drugs. Then we talked about POS, polycystic ovary syndrome, which is really a set of symptoms. We have enlargement of the ovaries because of these kind of irregular follicles that are forming in the ovarian cortex. So the cause is unknown, but it is linked to an increased amount of androgens, or male sex hormones. Some of the clinical manifestations, irregular periods, male pattern baldness, obesity is quite common, hirsutism, which is basically male pattern hair growth in females, and that's going to be due to too much androgens. So diagnosis, the Rotterdam criteria, this is just when you have at least two of the following: ovulatory dysfunction, polycystic ovaries, or androgen excess. Treatment is kind of directed towards suppressing the amount of male sex hormone that's being produced. Metformin is used also. So here you can see a normal ovary where you have this naturally developing follicle and then ovulation, whereas in a polycystic ovary, these follicles don't mature correctly, and this can actually cause infertility. Then we talked about the STI'S, starting with chlamydia, which is caused by chlamydia trachomatis. Clinical manifestations, discharge, dysuria, and a lot of people, especially females, it won't cause any symptoms, and that's dangerous because it can result in PID, but it can be treated with antibiotics. And this is the most common of the bacterial STIs. Gonorrhea. Gonorrhea is another, it's the second most common bacterial STI caused by Neisseria gonorrhoeae. This can spread to other parts of the body, particularly the joints, but also organs such as the heart. Clinical manifestations, again, dysuria, discharge. Here you're going to more likely see a purulent or a pussy type of discharge, especially in males. Sore throat, because this can set up infection in the throat, and again, this can lead to PID in females. But antibiotics will cure this. And then finally, syphilis is the least common of the bacterial STIs, and this is caused by a bacterium known as Treponema pallidum. Syphilis has a very complex life cycle that I'm not going to really get into here. I talked more about it in micro. So the clinical manifestations, it just depends, but it typically starts with what's known as a chancre. And the chancre is either going to be on the penis, and most often it will be in the cervix in the female. And again, antibiotics will treat this. Then we talked about the viral STIs. So genital herpes is these herpes lesions caused by either herpes simplex virus 1 or 2. The lesions will be similar to cold sores. They'll just be on the genitals. Again, once you have these herpes infections, they don't go away, but the flare-ups do go away. Genital warts, these are caused by certain strains of human papillomavirus, HPV. Most often type 6 and 11, but there are many other types that can cause warts. These warts can appear by themselves, or they can be in groups. It just depends. Sometimes they're very, very severe. A lot of people will actually clear the virus, so it's not like herpes where you can't really ever clear the virus, but not everybody will clear HPV. Trichomoniasis, this is actually caused by a protozoal organism known as Trichomonas vaginalis. Clinical manifestations, again, many are asymptomatic, but your typical sort of dysuria, discharge, all of that stuff. And then you have anti-protozoal medications that will treat this. And then we finished with pelvic inflammatory disease. So this is an infection, bacterial infection of the female reproductive organs above the vagina. So this is going to be cervix, uterus, fallopian tubes, and possibly ovaries, and sometimes even outside of those boundaries. Most often going to be caused by untreated chlamydia or untreated gonorrhea, sometimes both. And like I said, sometimes it can extend outside of the boundaries of the reproductive organs into the peritoneal cavity, which is very dangerous. This can scar the fallopian tubes and result in infertility or ectopic pregnancy. So it's pretty nasty. Clinical manifestations, a lot of people are asymptomatic when it's just an STI. And that's risky because if you're asymptomatic, you don't think anything's going on. But these bacteria are ascending higher into the reproductive tract. So at that point, once it's really PID, you'll probably have pain, discharge, oftentimes purulent. Again, that's associated more with gonorrhea. Fever, malaise, just a general feeling of fatigue. Diagnosis, history and exam, lab work. It's not difficult to diagnose, and this is going to require antibiotic treatment, probably both oral and IV antibiotics. And for more serious complications, certainly hospitalization and things like that. And here you can see somebody, this is a hysterectomy. Here's the uterus, these are the ovaries, and obviously these are very, very sick. So as always, if you have any questions, please let me know.